Okay, so I've started recording. So good evening, right? Welcome to the third session of this teaching enterprise, right? So we'll see how things go. Today we are going to learn about obstetrics, right? So let me pin my video so that not that I don't want your faces on this, but for the recording, I look like a hona when you see this video on a phone. So I will need to make myself look bigger. Right, pin. Okay. Right. Good. I can see Fujani. I can see Chamod right on top. And so you are the only two guys I can see, right? So therefore, please, when I ask questions, not do something so that I know that I'm getting through to you all. Okay? Right, fine. Now, children, so let's think about obstetric history taking. So what you have to do is, we have to understand this. Right. So we have to understand this obstetrics in a way that we look at the whole thing from above. Okay. And we need to grasp the whole picture, the complete picture of what obstetrics is. In the sense, now this concept was taught to me by my teacher, Mr. Dr. Dilip Viswanathan. I don't think you all have met him. He is the best teacher in the world that I ever met, right? And he actually taught me what I'm going to teach you today, right? He coined the phrase, or he invented the phrase of what is called an obstetric cycle. Right? So this is exactly what I'm going to teach you all today. To understand obstetrics and to understand how we go about it. So now the concept is this. A pregnancy is a cycle, right? It starts off with a preconceptional clinic, or it starts off before the person becomes pregnant. Okay. Then the person arrives at what we call a preconceptional clinic, the couple, and then gets advised and optimizes themselves for conception and a pregnancy. And then once the couple is optimized or understands exactly what needs to happen, once they get pregnant, they first of all come in for the booking visit, right? Where the initial meet is there with the doctor. And then after that, the plan for the pregnancy is formulated. And then we meet them at certain intervals while they progress along their pregnancy. So we meet them at, say, 20-21 weeks, where there are some certain things that we need to do. Then we meet them again at 28 weeks, 32 weeks, 34 weeks, 36 weeks, and then maybe weekly 36, 37, 38, 40. And then what happens is they go for their delivery, either at 38, 37, depending on the circumstances, they have their delivery. Now, delivery is two ways. Either she goes for a cesarean section, or she goes for a vaginal delivery. And the vaginal delivery can be a normal vaginal delivery, or a vacuum delivery, or a instrumental delivery. All these, once they deliver, they go to their puerperium, right? That is from delivery, it's 6 weeks. So after the puerperium, then after 6 weeks, the obstetrician's responsibility is over, and then they go back to their normal lives. And if they want to conceive again, Then they go back to the preconceptional clinic. So the patient goes around in a circle, or the journey is a cycle, right? And what we are doing as clinicians or doctors is that we analyze them, we look at them, we examine them, we modify their journey and try and make sure that this journey is safe and that we have the best outcome for the baby and the mother, and that they are safely, that they go through this journey. All right? So this is basically the philosophy that was taught to me by my teacher, Mr. Dr. Dilip Vishwanathan, and then this I am teaching to you all, right? So let's understand why we look at it like a cycle, right? So see, each specific patient has their own cycle. However, as clinicians, we need to understand that these cycles will differ from each other, because at certain points in this cycle, there may be certain interventions or problems that we might have to face and solve depending on what the patient has. So a patient who is completely without any problems, medical or otherwise, will go through this cycle, right, and come out of it, okay? The patient who has pre-existing disease, for example, diabetes, will have a different journey through this cycle. For her, the monitoring will be more. For the baby, the monitoring will be more, right? For example, if she has diabetes, then probably we'll be checking or monitoring a blood sugar every 1 to 2 weeks, right? Her time of delivery might be slightly different, while we might be delivering around 38 weeks. Then the delivery itself might give us problems like shoulder dystocia or in some problem during the delivery. The puerperium might be slightly different because she might get problems, she might have more infections, she might have different kinds of problems if she's diabetic, all right? So therefore, for example, heart disease. So the journey also is different. So what we mean by co-knowledge in the sense what we need to know is that we need to know each individual obstetric cycle for each problem. And that is only about maybe 60 or 65 cycles altogether. If you list out the types of cycles, we get about 50 to 60 or maybe slightly more. So see, which means basically the co-knowledge is we have to know as clinicians what needs to be done at what part of the cycle for each individual problem. So we need to know the cycle for a diabetic patient, we need to know the cycle for an epileptic patient, we need to know the cycle for a patient with heart disease or with hypothyroidism, single kidney, or say a heart disease like aortic stenosis, a heart disease and mitral valve problems, or psychiatric disease, or someone with deranged liver functions, or someone with pregnancy-induced hypertension, or someone with gestational diabetes, someone with twins. So the cycle, we need to know exactly what we need to know at each different time of the cycle. So that is co-knowledge. So that is what we have to understand, right? So that is the philosophy of taking a obstetric history. Now, what we do as clinicians is, say, if we meet in our co-knowledge, right? Say, if a patient comes without any problem at all, a normal patient with a normal pregnancy. Say we meet the patient as a doctor, you meet them at 36 weeks, right? So Now in our minds, because of the core knowledge which we should have, we know exactly what should have happened to her until 36 weeks. For example, we know ideally that she should have had a preconceptional visit. Ideally, she should have had a booking visit. Ideally, she should have had a visit between 21 and 22 weeks for an anomaly scan. Ideally, she should have had a oral glucose tolerance test, a full blood count, and screening for several other problems at 28 weeks. Ideally, maybe we should start charting the baby's growth around 28 weeks. Then we should have met her at about 32 weeks, 4 weeks from there. Then we should have met her around 34 weeks. And then at 36 weeks, there are certain things we should have met and there are certain things we should have done. So now we know that ideally what should have happened. Now, what is our history? Our history is basically, did these things happen the way they should have happened? So what we do is, as obstetricians, we compare the ideal of what should have happened to what has happened, and that is your history. Now, as MBBS students, right, or students who are sitting for their MBBS, what we expect from you all at MBBS level is a chronological history, which is the easy part. What is a chronological history? What happened when? Okay. In the booking visit, did these things happen? Since in your core knowledge, you need to know exactly what should have happened, right? If you compare what has happened with what should happen, then it's even better. What are we looking at? We are looking at an analysis. So that's called an analytical history. Yes, at MBBS level, if you just give us a chronological history up to what has happened, that's fine. If we ask a question, okay, at 28 weeks, what do you think should have happened to this patient? And then if you say, okay, an oral glucose tolerance test should have happened, but did not happen. Maybe a full blood count should have been done to check whether she's anemic at that point, but it was not done. Now, what are you saying? You're already talking about an analysis, which is going to give you more points, and you are going to make the examiners smile. You all understand? So that's an analytical history. But analytical history, we expect from the postgraduates. We expect them to analyze each small point, correlate and analyze. But from you, the minimum of a chronological order is essential. And when you ask a question, yes, you should be able to answer, okay, this should have happened, but has not happened. You all understand? So you get that chronological history up to say 36 weeks if you have a patient at 36 weeks. And now, you know, for this patient, looking at what has happened, and if it is completely normal, from 36 weeks onwards, what are the things that should happen? Say we will meet her weekly now, right? 37, 38, 39, and 40. If everything is normal, maybe we will admit them, okay? And now, after admission, we need to deliver them. If they don't go into spontaneous labor, probably we will induce them. And once we induce in a certain manner, they will go into labor, they will go through the first stage, second stage, and the third stage of labor. And after that, right, once the third stage is over and everything is done, they will go to the puerperium, where we need to teach them certain things. And there are principles of the puerperium which we need to understand. So they are looked after in the puerperium. And then after the puerperium, they go back to their preconception clinic in the future. Now from 36 weeks onwards, until they complete their puerperium, that is your management. You all understand? So the commonest question that is going to be asked from you all, once you give the history, say this, we are talking about a patient at 36 weeks, right? Once you give the history till 36 weeks, the commonest question you are going to ask them, okay, how are you going to manage your patient from now onwards? So basically, what it means is you have been asked what you are going to do at 36, what you are going to do at 37, what you are going to do at 38, 39, what you are going to do at 40. How are you going to manage the labor? Is there anything special you need to do at the first stage, the second stage, and the third stage? And is there anything that you are going to do during the puerperium? That is your management. Do you all understand, children, the philosophy behind the whole concept? So if you meet a patient at 34 weeks, until 34 weeks, it is your history. From 34 onwards until delivery and puerperium is your management. That is what you are expected to say. Got it? If you meet a patient at 40 weeks, up to 40 weeks is your history. From 40 weeks onwards, what you're going to do is going to be your management. So that is essentially the obstetric cycle and obstetrics in a nutshell. Got it? So the core knowledge is what you need to have. And what is the core knowledge? What each condition is. Maybe in obstetrics, there are about 60 or so common conditions. Okay. And we need to know the obstetric cycle of each of these conditions. Right? So if you know all these 60 and what must be done at what time and how things must be done during each phase of the whole thing, then of course your obstetrics becomes easy for you all. Okay. So that is what is we expect of the MBBS students. Okay. Now, it is not my intention to teach you 60 obstetric cycles today. That is up to you all, right? There are certain books that there are with obstetric cycles. There are more than enough textbooks, online discussions for each condition. So what you need to do from today as MBBS students, now groups, I have advised my groups are there because there will be about 30 or so in each group, to get the list of obstetric conditions, the common conditions, and I will ask my senior registrar to post it for everyone, right? So that we have it. So about 60 or 70, I'll just ask in the post. What you do is, all of your children get a common format, right? So you say, first the preconceptional clinic, then you get the booking visit, then you get the first trimester, second trimester, third trimester, then you get the normal delivery, first stage, second stage, third stage, or you can say one thing, one box about say delivery, which can be divided into first stage, second stage, or third stage, or if it is a cesarean section, preoperative, intraoperative, postoperative. Okay, and then the other box will be the puerperium. Okay, so you have a cycle with set places or intervals, and then with your textbooks, with whatever material you have, for each of the 60 or so conditions, say diabetes, heart disease, aortic stenosis, psychiatric illness, renal disease, renal failure, transplanted kidney patient, right? Bronchial asthma, whatever these conditions, right? You fill in these boxes looking at your textbooks, and basically you are compiling your own obstetric cycles. Okay, so in your mind, when you get a patient with one of those cycles, now you know what exactly must be done for this particular patient, or should have been done up to now, and what should happen from there onwards. So then obstetrics becomes relatively easy, but we are only talking about history taking. Okay, obstetrics is not easy as such because it needs a huge number of technical skills to go with it to manage a patient, right? From delivering, from a instrumental delivery, from managing a postpartum hemorrhage and managing obstetric emergencies and managing the surgical complications and doing surgery. But however, for the MBBS, right, for you, the core of what you need to know is basic history taking and basic management. And if you know all these 50, 60 obstetric cycles, I assure you, it'd be very, very easy for you to do well, very well in the exams that are to come. Okay? Did you all understand? All right. So I will now just ask a few questions from you all. Let me. Okay, not questions. You all can ask me questions. Yes, children. Any questions that you want to ask me about this particular bit? I just want you all to have an overview, a bird's eye view of this thing. Okay. Any questions that you all have up to now before I go into specifics about the cycle? Anything? Okay. So which means that you all have understood this so well, right? Okay. And having AOs. Okay. Right. And so let's move on then. Okay. Right. Fine. So now let's get on to what we need to know. So what I'm going to do is to take you through a normal obstetric cycle as to what must happen with each, and I will discuss very shortly, right, slightly about what should happen with each. So basically I'm taking you through a normal obstetric cycle, children. You all understand? Once I do that, so that you have an understanding as to what must happen at what visit, right? From there, I will take you all on to show you how to take a very quick obstetric history. So I have asked one of my demonstrators in the faculty, so she will act like a pregnant woman, and I will take a very short history so that you all understand how a history is taken. Basically in your exam format, right? Which is what you all require when you give an exam. So you should be able to take a very, very quick, good history so you understand exactly how it is done, right? I will demonstrate that to you at the end of this session, right? Then let's start off, right? So I'm going to touch on, children, on principles of each of these. So now what is a principle? Because medicine is built on principles. If you understand the principles, the small bits of knowledge that you can put into those principles, you all can fill those in as time goes by. So with that, experience will accumulate and knowledge will accumulate. But you need to know it all falls under very large principles. So I'm going to talk about principles. For example, now I want to understand. If we say, I'm going to give you morphine or pethidine for pain relief, that is not a principle. However, if I say, or if I talk about, okay, I'm going to talk to you about analgesia. Now that is a principle. You all understand? Pethidine or morphine comes under that. And just one medication, right, which can be used. So we need to talk about analgesia, right? So that is the principle. You all understand? So therefore, I'm going to talk to you about principles of each of these. So the details you all can fill in later, which is what you have to do by yourselves. Okay, right. So now let's start off with the pre-conceptional clinic. So basically we are starting there. Then I'll take you round and come back. Okay. So if you look at the preconception clinic, ideally, all couples should come and meet a clinician or an obstetrician before they plan or try to get pregnant, right? So what are these? The intention or the philosophy of the preconception clinic is to optimize the couple for a pregnancy and to try and minimize the problems that might come along the way for them. Okay? So, for example, if a woman has diabetes, pre-existing diabetes, at the time of conception, right, if the woman has uncontrolled diabetes, the chances of fetal anomalies become higher at the time of conception. So in the first cell, when the sperm and the egg meet. So if she has diabetes at that time, uncontrolled diabetes, chance of having anomalies in that cell is higher. And then it divides into a baby, and the baby is going to have anomalies. However, at the time of conception, if she is well controlled, even if she is diabetic, then the chance of having fetal anomalies will go down. Do you all understand? So therefore, what we are trying to do in a preconception clinic is to minimize the risks and make the couple have the best possible outcome of having a healthy baby and a healthy mother, right? Got it? So that is the principle, the main principle. Okay. The whole of this preconception clinic is divided into two, right? As with any classification. Remember, in your brain, when you're talking about any concept, anything, try and classify it initially to the widest possible, or do the widest possible classification possible. If you're asked about contraception, children, okay, tell me, okay, and I ask you, don't worry, I'm not going to ask you all, I'll answer my own question. Say if I ask you, right, classify contraception for me, okay, the widest possible classification, you classify to men and women. Okay. Then under men, there'll be certain things, and in the women, there'll be certain things. So if you think of the whole classification, contraceptional, oral medication, or hormonal, non-hormonal devices, all those will come later, because all those will come under men, all those will come under women as well. You'll understand? That's the widest possible classification. So therefore, when you are answering a question, try in your brain, right, to classify that problem into the widest possible classification. So if you say, okay, if you talk about hormonal, non-hormonal, this thing, if you miss men all out together from contraception, you are losing 50% of your marks. You all understand? So you need to understand that it has to be classified into very, very large portions, or the biggest possible things along, right? So now let's classify the preconception clinic into two large portions. What are these? The biggest, right, probably is general advice that is given to every woman or couple who plans to get pregnant. Okay. The second biggest portion is specific advice given to specific women with specific problems. Do you all understand? Right. So if you get general advice, what are these? Common advices that we need to give women who are planning to, or couples who are planning to get pregnant. Number one, we have to talk, now we are talking about sub-principles, okay? The first principle is we have to tell them about prevention of fetal anomalies before it happens. Okay, this is general advice. What is the thing that we know? We know that folic acid supplementation, 400 micrograms, 3 months prior to pregnancy, continued into a pregnancy, may prevent in certain women neural tube defects. So therefore, folic acid is advised. That is the only micronutrient that we know at the moment, which has some evidence to say that it helps. Okay. So that is supplementation, or trying to reduce fetal problems. Number one. What is the second principle which are going to talk about? The second thing is we need to tell them about a healthy lifestyle, right? They need to lose weight, exercise, right? So that they have a healthy lifestyle, which is also a general advice that we want to give them. The third thing is we need to tell them about the frequency of intercourse, right? That is the third sort of principle written. So now, there are a lot of myths about the fertile period. These are myths because once the egg comes out, ovulation happens, the fallopian tube will pick up the egg from the ovary and keep it at the end inside a pool, right, like a swimming pool, for 2 days, about 48 hours. The egg will live there. And if the woman has sexual intercourse once, the sperm will travel and live at the end of the tube for about 3 to 5 days, sometimes even up to 7. Right? Shall we say 3 to 5 days? Okay. So if a woman has sexual intercourse 2 to 3 times a week, or even twice a week, there'll always be a store of sperm waiting for the egg at the end of the tube. So from there comes the advice based on science that a woman needs to have sexual intercourse 2 to 3 times a week, right, to conceive. That is number one. All right. And the other also, since there are ovulation need not coincide with sexual intercourse for the woman to conceive. That is number one. Number two is at what time the ovulation occurs is very difficult to say. It's never what you say right on the dot on 14 days. Never. So therefore they vary. So therefore, since we cannot time ovulation very much, right, it's advisable to have sexual intercourse 2 to 3 times a week throughout the cycle. So that is the general advice that you give. If you have a fertility period, and if you do fertility kits, measure certain things, try to mark on the calendar, okay, this is the time we need to have sexual intercourse, right? And you try to have sexual intercourse on a timetable, that becomes a stress. And stress produces an ovulation. So that is counterproductive for the couple's fertility. Do you all understand? So the general advice that must be given, if you want to conceive 2 to 3 times a week, have sexual intercourse without a timetable, no fertility periods throughout the cycle. So that is the general advice. Okay, right. So we have covered folic acid or supplementation. We have covered a healthy lifestyle. We have covered the frequency of sexual intercourse. The next thing is immunization. What are the minimum immunizations that needs to be given? Rubella. Okay, because rubella is a devastating disease, can cause a lot of fetal anomalies and problems, right? It destroys certain parts of the fetus. For the mother, it might be just like another small infection, which she might not even notice. But for the fetus, it has devastating effects, and immunization can prevent that. So she needs to be immunized for rubella. Now, if she doesn't know that she is immune or not immune, just simple blood test, rubella, immunoglobulin G. Now, if she is not immune to rubella, in the preconception clinic, you can ask to get it. And then she can wait for another, once the immunization happens, maybe 3-4 weeks, 6 weeks, maximum 3 months, then she can try to go for a pregnancy. Okay. Other hand, if she has been given rubella inadvertently in pregnancy while she was in early pregnancy, still no problems have been found. So termination definitely is not indicated for anything. So we can advise her there have been no other problems have been found with inadvertent immunization is revealed during pregnancy also. Okay. However, if we find that she is not immune, we are not going to immunize her. We are going to tell her once this baby is delivered, once after she delivers, then go and get a rubella immunization for the next pregnancy. Is that okay? Do you all understand? The next is chickenpox, not a must. But if you have not had chickenpox, then you can get it if you want, but it is not coming to our guidelines for them to have a chickenpox. Now, of course, immunize COVID. If it's always better to have had the COVID injection, right, before she gets pregnant, and it is completely advisable, and we advise them to get the COVID during pregnancy as well, right? So pregnancy is not a contraindication. Actually, it's a must that they must get their COVID immunization or vaccination during pregnancy as well. Okay, right. So those are the immunizations that she needs to get. Next, so these are the general advices that need to get, right? So then, so once we have spoken about those, these are the general things that we tell every woman who wants to get pregnant, right? Next, the general advice is for the man. And normally, we will tell them to try not to smoke, okay? If they are smoking. In females, of course, in Sri Lanka, we hardly ever see any patients who smoke. But if they are smoking, it's better to stop. So that is a general advice. And they have to try and avoid medication that might cause problems as well, like drugs, right? Recreational drugs, right? Those things also are not good if you are trying to get pregnant. For the man, the most important thing is smoking, because cigarette smoke, or has so many toxins that might have an influence on the spermatozoa, the quality of the spermatozoa. So that is the one advice that we can give. Okay. And of course, for the male, a healthy lifestyle, to lose weight if they are overweight, right? And these are the things, because that will contribute towards his performance in trying to get his partner pregnant. Okay. So those are the general advice that they give, right? Now let's get on to specific advice. Specific advice is, there are two types of women who we will give specific advice. The first type are women who are coming with specific problems which have been diagnosed. She will come and tell you, doctor, I have diabetes, right? And I want to get pregnant. Can you advise me? Or doctor, I have a renal problem. Doctor, I have a heart disease. Doctor, I have hypertension, right? And then you need to give specific advice to that. The second part, or the second group of women, are the ones who come to you for preconceptional advice, and you find a problem in them when you examine them. So those also we need to give the advices or do the necessary referrals. So if a woman comes to us with a problem, diabetes, hypertension, heart disease, anything, what we do is, we do the specific referrals in the preconception clinic to optimize their disease to the relevant specialist. Diabetes, general physician or endocrinologist. Heart disease, to a cardiologist or cardiologist. Say if it is hypothyroidism, an endocrinologist or a physician, right? If it is a renal problem, to a nephrologist. So we send each, or if it's a psychiatric problem, to a psychiatrist. So we send each of these women to make sure that they are optimized before they try for a pregnancy. If we do find a problem at that point, depending on the pregnancy, we do the needed reference. So that is what I mean by saying we need to specifically we might need to treat a few patients differently. That is number one. Number two, in this category, one other general principle is contraception. Until she is controlled, we give her a form of reversible contraception, not long lasting, not long lasting. We don't give them Depo-Provera, right? That is, you give them and it will take 3-4 months or even more for her to get back to a normal. So we give them reversible contraception depending on the case, so that once whatever she has is fully controlled, then we can take off the contraception and again she can go and try and conceive. Understood? So the second thing is contraception in this group. Okay. So those are the two important. So specific problems with specific patients, you give specific advice and do the specific reference. You talk about contraception to them and give them reversible contraception, so the contraception can be reversed at any time. And general principle covering everything is that you need to communicate with them very well, and at the same time give them resources, if necessary pamphlets or websites or wherever, where they can get specific or good information about them, because there's such a lot of things out on the net which are not peer reviewed. So it is our duty to tell them to go to sites which give very, very good peer reviewed proper advice. So you can recommend few of those. Okay, if you want information, go there. If you want information, go there, without reading a lot of social media where the information might not be correct. Or alternatively, you can give them printed matter or electronic matter which you have compiled for your patients in your clinic, giving specific advices for specific people. Do you all understand? So do you all understand the general principles of a preconception? For example, if a patient comes with diabetes, then you might need to advise them before they conceive, they need to take 5 milligrams of folic acid, not 400 micrograms. Okay, so that might prevent defects later on. So if they, in the past, if they have had fetal anomalies, for this pregnancy, we might address them 5 milligrams, a high dose of folic acid preconceptionally than the normal dose. So these are specifics that you will need to understand and comply with. Got it? So that is the preconception. Next, they become pregnant, right? And they come to you and meet you at the booking visit. Okay, so we have passed the preconception. Now we are at the booking visit. Is that clear, children? Right. So now the booking visit basically is the time, if they did not come to the preconception, is the time you meet the patient. That is the first time you meet the patient. The booking visit has certain principles, okay, where you need to remember. The first principle, of course, is introduction. You need to get to know your patient, who it is, what her name is, what her age is, what she is doing. So you know, build a rapport with the patient, right? And talk to the patient and then gain her confidence. Basically, once you have had your interview, right, the patient should be able to tell someone else, look, the doctor is so good, I would, you know, I want to go to that doctor again, right? If the patient goes away saying, something wrong with that fellow, I don't want to ever see him again, then you have not done a very good job about communicating. Okay, so be the doctor, the patient wants to come back to you again. Okay, so try and work on that. Right, so that is number one. The next thing is, once you got the introduction to the patient, the next principle that we go about is dating the pregnancy. Okay, we need to date the pregnancy. So how do we date the pregnancy? Number one is we date the pregnancy with the last regular menstrual period. And we use the Naegele's formula, where we add 7 days and 9 months to a last regular menstrual period. The whole of these is based on one single fact, is that we think that the pregnancy is of a certain length, which has been calculated by taking lots of pregnancies, adding all them and dividing it by the number, and you have got a number of days, which is 9 months and 7 days, okay, as the length of the pregnancy. That is number one. The second thing is, okay, I have a, excuse me, we are breaking off. You are breaking off. Can you all hear me now?
There haven't any issues.
Was there a break at some point?
No.
Okay, probably Nilesh, it's your connection, right? Was I clear all the time? I can see Chamod,
Yeah.
I can see, yeah. So
Yeah.
I can see Chamod. Chamod, you wave at me if I break off, okay? Right? Because you are sitting right on top of my screen and you have been there constantly. I don't know how you got there, but you are there all the time, okay? All right. Muka karat Chamod din na tan aparadi yan na ba, okay? Right, fine. Nilesh, hopefully you are back. Is your line back? So Nilesh said I'm breaking off. Okay. Right. So, oh yeah. Yes, sir, he says. Okay. Where were we? Right. Okay. Right. So what happens is we can do the Naegele's formula where we add a certain amount and get the expected date of delivery. But we are relying on certain things to do that. Number one, we postulate that the pregnancy is exactly this number of days. The second postulation is that the ovulation happened exactly 14 days after her last regular menstrual period, first day of her last period, right? But that hardly ever happens because ovulation may not happen exactly 14 days. It can happen at 10 days, 7 days, 14 days, 17 days, 20 days, we do not know. Okay? So therefore, if we do the Naegele's formula, yes, it might be correct and it might not be correct, number one. Number two, it has been found that 40% of the women, close to 40%, do not remember their last regular, first day of the last regular menstrual period correctly. Right? And therefore, if you base your calculation on that, there might be a mistake. So that is number one. The second thing for dating, which we do then, is we go for an ultrasound scan, which is usually a transvaginal scan. And the best time to do that is between 11 and 13 weeks. Okay? That is where the crown rump length correlates exactly with the gestational. There's a linear correlation of the gestational age with the crown rump length. Okay? So if we do the measurement of the crown rump length, which should be in the proper shape, in the proper angle, in the proper orientation, right? Because the baby has to be in a certain way, certain orientation. Then we can calculate the gestational age very, very well. So once we do that, then we have a very good calculation or an idea as to exactly the gestational age, and then from there we can calculate the expected date of delivery. Okay? The general principle is, if our date calculated by the LRMP is not more than plus or minus 2 days from our ultrasound scan dating done between 11 and 13 weeks, we will go with the LRMP with our normal formula. However, if there's a difference of more than 2 days or difference between the LRMP date and the scan date, we will always go with the ultrasound scan date, right? However, as time goes on, say 15, 16, 17, 18, 20, if you try to date at that time, then there is a possibility that there will be more errors. But the ideal is to date between 13 and 15 weeks, 11 and 13 weeks. Is that clear? So that is how dating is done. And then with the dating, once you have done the expected or date of delivery, you should be able to calculate the period of gestation. You calculate the period of gestation thinking that expected, since we know the expected or date of delivery, then we either calculate, you count the number of days to today's date and then find out how many weeks there are between today and the expected date of delivery. And then you deduct it by 40 and you get the period of gestation today. You all understand? Or you calculate forwards from the last regular menstrual period, right? That is possible if the LRMP is correct, as to how many weeks up to today, right? And then you say what the period of gestation she is today. Is that clear? Right? So basically you need to know the period of gestation. Okay. So for the booking visit, the first thing what you have to do is what? Dating. And you have to make sure you get the dating correct. And then you have to decide on one date, proper date. And that is what you go with throughout the pregnancy. Because the period of gestation is going to give you exactly all the rest of the measurements during the pregnancy. So if you want to say that your baby is not growing well, or if the baby is growing too large, or whether there's a problem, right? We always correlate it and have charts for the period of gestation. So if we get the period of gestation wrong, then all the rest of our conclusions are going to be wrong. Even delivering the baby, if we can't say past dates or before the dates, because if we have got it wrong, then we have got it wrong. And that will cause a lot of problems. Days for induction, days to find out whether the baby is too big, too small, at what centile is growing, whether to diagnose small for gestational age, anything is extremely important for us to know the dates. Correct? Right. Then comes our next segment. First is dating. The second segment or the next segment in the booking visit, which is very important, is along with the dating, the best dating is done with the transvaginal scan. In the transvaginal scan, there are certain things that we look at. Number one, we look at the dating first. Number two, we start the screening process there to see whether the baby is all right. What are the few things that we look at commonly? If there are gross anomalies, whether the baby is swollen up or whether there is an excess amount of fluid around the skin, right, where it might be due to certain genetic anomalies. The second thing which we look at is the nuchal translucency. Nuchal translucency is the thickness of the baby's neck here. Okay? Why there? Because it is thought that babies with genetic anomalies, the lymphatic system here is not very well developed. And therefore, the fluid reabsorption or getting that fluid out back into the circulation is not great. And therefore, that it becomes more thick. So you measure the nuchal translucency between 11 and 13 weeks. Okay. And if it is large, then it gives us a suspicion or that there may be some gene abnormalities, and then you will need to do specific tests to find out whether there's a problem. Remember, it's a screening test. Now, what is a screening test? Very simply put, screening is something which you do by doing a certain investigation or an observation, right? Whether it might be clinical. You divide the whole population into two. One is high risk and the other is low risk for that specific problem. Okay? And you take that high risk group and do a diagnostic test for that to find out whether the disease is really there. Is that clear? So if you ask what screening is, basically you are dividing a population into two groups by using some test, and one group is low risk, other is high risk. So in the high risk group, there may be A lot of patients who do not have the disease. However, in the low risk group also, because it's just a screening test, there may be patients who are having the problem as well, which you have missed. Okay. And then for the high risk group, we do the diagnostic test. That is done because it is sometimes may not be practical for us to do a diagnostic test for the whole population. It may be too expensive or too invasive, so we don't do that, right? So therefore, we choose certain screening tests to divide the population into two. So one thing, so the nuchal translucency is a screening test. Second is the appearance of the nasal bone, right? If it's their absence, maybe a certain bit of alarm bells might ring. So those are the few things that we look for screening in the patient during the scan. What next? We check whether it is single, multiple, or pregnancies. If it is multiple pregnancy, we check for chorionicity. Chorionicity is whether it is monochorionic or dichorionic. How do you divide that? Basically, if it is a single placenta, the membrane comes off like that, like a T. Okay. If it's dichorionic, basically both there'll be two placentas. So therefore, the two choriones will merge into the membrane like that, because there are two placentas. Okay, logically, one placenta, if there has to be two babies in two sacs, diagonal, so there the membrane will come like that, and you see a T. So dichorionic, they will merge into the placenta. So you don't get a T, you get a thick membrane at the beginning. So that's called a lambda sign. Do you all understand? So that's dichorionic. Okay. So you check for chorionicity. That is very important as well. Next, you check whether the babies are alive. So if there are two, one might be alive, one might be not, one might be growing, one might not. So you can check that as well. The next thing is you need to check where the baby is, whether it is cornual, whether it is near the cervical, whether it is properly there, or whether it's not there at all. It might be an ectopic. Okay. Then you check whether there are any problems with the uterus, like fibroids. Then you check whether there are outside the pelvis, whether there are masses in the ovaries, right? So you check whether the kidney, there's a pelvic kidney or not, you know. So you check the whole pelvis, right? And then you if you diagnose certain things, then you can expect problems, or you'll be ready for the problems as they come, right? So therefore, these are things we look at it in an ultrasound scan, not merely dating. Got it, children? Yeah. So that is dating. That is the second principle. Okay. And there's a bit of screening included also. The third principle is screening. So we have done a bit of screening in the scan, but there are other specific ways of screening. So now we are talking about the third principle in the booking visit. Okay. Screening, we can say we did nuchal translucency, we did presence of nasal bone, right? Those are things that we, or gross anomalies, which you can see, that also will give us a bit of screening. But for screening, specific screening, we do biochemical and then we do free fetal DNA. What is biochemical screening? You check certain biochemical markers, depending on whether they are high or low, we come to a certain conclusion that this woman might be high risk for certain genetic abnormalities like Down syndrome, like trisomies, right? So you check specific markers depending on in some conditions, some biomarkers will be higher, some biomarkers will be lower. And the amount that they vary, whether it's 2 times, 3 times, 5 times, whether they drop by 20%, 30%, so depending on that, you come to certain conclusions saying, okay, this might be this, and this is high risk for that. You all understand? So certain biochemical markers are done. Depending on the, you come to a conclusion as to, okay, this seems to be high risk. So different conditions might give different variations in the biomarkers which are done. So that's why. And then you combine several biomarkers together with the age and everything, and then you can come to a, you say, okay, this woman falls into a high risk group. Got it? So you can do it for Downs, you can do it for other trisomies, different genetic problems, and then you come to conclusion. So these are biochemical screening. So for example, for Downs, you can have double test, triple test, quadruple, combined test. All these are biochemical screening. This seems to be going out slowly a bit. Why? Because there's another screening method has come. The new boy on the block, as they say, right? What is that? It is testing for free fetal DNA. It has been found that the baby's DNA is floating, not the cell, but the DNA is floating around in the mother's blood during the pregnancy as early as 9, 10, 8 weeks. But the best to do it around after 11 weeks. So you get the mother's blood, isolate the fetal DNA and check that DNA for problems, which is called free fetal DNA. So it's a non-invasive test to get the baby's DNA, right? And this seems to be, it's widely used, it's there in Sri Lanka as well, right? Where you go for screening. However, it's still a screening test. So if there is a problem, then if the screen is positive, then we have to go and do a diagnostic test. Now, what is a diagnostic test? You need to either put a needle into the placenta and get a bit of villi, so chorionic villi, right? That's a CBS or a chorionic sampling. Or you need to put the needle into the amniotic sac, draw a bit of fluid and isolate the cell from there, which is what is called amniocentesis. You understand? Or you need to put a needle into the baby's cord and get some blood, baby's blood from there, which is called chordosynthesis, right? All this can be done. So that is specific diagnosis, or it's a diagnostic test where we do the surgeries. Do you all understand? So the third principle in the screening process, the booking visit is the screening test that we use. Okay. The fourth principle in our booking visit are the investigations. All right. So what are the investigations that we do? Number one, we need to do the full blood count. Why? Basically, we look at the platelets and the hemoglobin to see whether they are anemic. Second, we do the grouping and rhesus. Why? Basically, to see if it is rhesus negative, there may be certain things which we need to do throughout the pregnancy, like giving anti-D injections at 28, 34 weeks. That is anti-D prophylaxis, right? Where we try to prevent silent fetal-maternal hemorrhages causing maternal isoimmunization, right? It has been found that after about 28 weeks, silently the mother in a rhesus negative mother, if there's a rhesus positive baby, the cells make their way across to the mother silently. We do not know. There is no aggravating sort of incident. And then that causes the mother to get sensitized. So therefore, at 28 weeks, what we do is we give an injection. What do we give? Anti-D. We give the injections against the rhesus positive cells. So the mother already has antibodies circulating in the body, and if the baby's positive cells come, it immediately covers it up. So the mother's immune system does not see it, and therefore it prevents isoimmunization. It works for 6 weeks. So you give it at 28, then you give it at 34 weeks. From 34 weeks, you give an injection, it covers the mother till 40 weeks. After delivery, you give another postpartum injection as well. Clear? Right. So that is why we do it. Second thing is, it's necessary for us to find out whether it's a rare blood group with problems, where then you can have to be ready with the blood, or in any postpartum hemorrhage or anything, or in antepartum hemorrhage, whatever the problem is, we need to know exactly what the blood group is. So that is the second thing. Third thing is VDRA, venereal disease research laboratory test. What is it used for? To screen for syphilis. Because syphilis has devastating effects on the baby, right? So therefore, however, if it is diagnosed, then it is curable and controllable. So therefore, if VDRA is positive, it's a screening test. What is done is a specific test are done by the SCD specialist, right? Treponema pallidum, hemagglutination, all these specific tests. If syphilis is properly diagnosed, then it can be treated, and that will prevent the baby from having problems. Okay? VDRA. Then HIV. HIV 1 and 2 are done. If it is positive, then there are lots of things that can be done to prevent the mother having problems and to prevent the baby from getting HIV. It is optional. You cannot force a woman to have a HIV test, right? So you have to get consent and then do the HIV test for her. So in certain countries, it is optional. In certain countries, it is done without consent. So, but it depends on wherever you are living. So HIV, because it will influence her social status as well as insurance status. So all this in certain countries. In Sri Lanka, of course, we routinely anyway do the HIV as well, right? So, but in some countries, it is essential to get verbal consent before HIV, right? What is very important is if it is positive, the staff can get take precautions against getting infected, as well as there are lots and lots of things that because the management of HIV has advanced such a lot that we can basically control it so much that the outcome is almost similar to any other pregnancy, right? And we can also do a lot of things to prevent transmission to the baby so that the baby does not get be born within the infection, right? So that is HIV. Next is HBS antigen or the hepatitis B surface antigen. If the woman has Hep B and surface antigen, it's a screening test. She needs to go through the complete Hep B screen. And that will tell us whether it is a chronic disease, whether it is an active disease, whether it is certain things like HPE will tell us whether it is very infective or not. And therefore, there are a lot of things that we do during the delivery and after the delivery to prevent the baby from getting it, like giving the baby immunoglobulins at delivery and then giving the baby vaccination. And then there are certain things that we need to do to make sure that the baby, the woman is also well during her pregnancy, where we have to liaise with the relevant specialist to manage the patient. So that is HBS. And how many have I said so far? 5, right? The next is Chamod, 5, right? Please count. Okay. Then the next is the UFR. Remember, it is essential to do UFR, urine culture, and antibiotic sensitivity tests. There's no point in doing just a UFR. You have to do UFR because it's very difficult to interpret a single UFR, just a UFR. You have to do a culture. And if the culture becomes positive, you need to treat the woman with antibiotics to make sure that she does not get an, if the infection is not going to, because an infection can cause, because the urethra is quite distended, sometimes she can get pyelonephritis, right? So therefore, you have to give her antibiotics, give for 3 to 5 days. In Sri Lanka, one of the commonest antibiotics we use is nitrofurantoin, right? Where a lot of women are sensitive, or cefuroxime can be used. So we do not use normally coamoxiclav. So cefuroxime, amoxicillin, nitrofurantoin, those are the commonly used antibiotics. We give it for 3 to 5 days and maybe sometimes 1 week, and then wait for another 3-4 days without antibiotics, and we repeat the culture and ABS to see whether the urine infection has cleared. Okay, so it is essential to do UFR, urine culture, and ABST at the same time. ABST is done if there is a culture growth, right? But UFR, urine culture is essential and not just a UFR as we sometimes say. Right. Next is if we are not really sure whether she is immune for rubella or rubella immunoglobulin G is important. The next blood test that we need to do is a TSH to check for thyroid functions, and we need to supplement them with thyroxine if the TSH is high or if the T3, T4 is low, right? So that is the thyroid function. It's essential for the woman to receive proper dose of thyroxine, or it need to be euthyroid during a pregnancy and for the fetal protection as well. The next thing is, important thing is, I have covered that, and right, a test for diabetes. Okay, now for high risk women, we will directly do a diagnostic test. High risk means clinically it would indicate, say, a large baby, past history of gestation diabetes, frequent UTIs, candid infections, past baby with born with fetal anomalies, a past large baby over 3,500 grams, right? In other countries, 4,000. In Sri Lanka, we take probably 3,500. Advanced maternal age, all these baby with very specific defects, that was for diabetes, for example, sacral agenesis, or any fetal anomaly for that matter, right? All these probably is better do a oral glucose tolerance test as a diagnostic test, direct, if they seem high risk for having diabetes already. If not, if there are no risk factors that have been there in the clinic, right, in the history, we can do any screening test which you want to, right? A screening test is, remember, a test that divides the whole population into two. What are these? You can do a random blood sugar, you can do HbA1c, you can do a postprandial blood sugar, you can do a fasting blood sugar, or any test, or you can even a urine sugar test. All these are screening tests. So the commonest use is a postprandial blood sugar. 2 hours after a meal, blood is taken, and usually a PPH of over 140 would make the screen positive, and therefore depends on the values that you take. So if you take 140 as the cutoff mark for a postprandial blood sugar as a screening test, then that group that has more than 140 will undergo a diagnostic test, which is a 75-gram glucose tolerance test. 10 hours fasting, she gives in the blood test fasting blood sugar for the fasting, and then she's given 75 grams of glucose in 300 mils of water. Then 1 hour and 2 hours later, 2 more bloods are taken. So commonly used tests is 3 different schools, different schools of thought, different types will use different types of oral glucose tolerance tests. This is what I personally use, and the values vary widely depending on the guidelines you follow, depending on your personal beliefs, depending on the evidence. So they change. Personally, I use HAPO guidelines, which dictates that 62, 92 for the fasting cutoff mark, 180 for the first hour, and 153 for the second hour. But remember, these are not absolute. These are things which it may change with time to time. It changes with different research or work coming in, may change with guidelines, lots of things. So WHO guidelines, there are college guidelines, there are Royal College guidelines, there are different types of guidelines there. So it all depends on what you use in your own unit, right? Personally, what I use is what I told you. Fasting is 92, first hour is 180, and the second hour is 153. So anything over those, even one value, you consider the woman to be having diabetes at that point, right? So these are the blood tests that are done in the booking visit. Have I gone through everything? 8, right? 8. Do you have 8 there? Shamod, you are supposed to answer me tuck like that.
They're right.
Excellent, Shamod. Beautiful counting. Right. So therefore, that is the investigation. So in the booking visit, what have we gone through? Tell me again. We have gone through dating, right? We have gone through investigations. We have gone through screening. Okay. What else have we gone through? Is that all? Yeah, only 3 principles. Talk to me.
So introduction.
So introduction was the first one.
Introduction.
Then the dating. Then the
Investigation.
Dating. Investigation.
screening and the
Screening. Immunization. Did I go through immunization? No. Right. Immunization, right? Okay. So immunization is simple. For COVID vaccination, get it. Okay. Rubella, if you have not got it, you can't do it, but you have to test for that. Okay. So that is the immunization process. Next, supplementation. The next principle. Okay. Supplementation in some countries is universal. Everybody gets calcium, everybody gets iron. Okay. However, that should not be the ideal way. Iron needs to be given to women in countries where women are anemic. Or specifically, if you tailor make it for the women, then if the woman is deficient, then you can give iron. Do you all understand? Calcium need not be, supplementation need not be universal. So if it's deficient, or if there's a principle in the country, or a generally agreed upon way, you can supplement it universally. So in Sri Lanka, for the moment, there seems to be an acceptance of universal supplementation, but you need to understand that it is not absolutely essential. So calcium and iron. Okay. If you are taking iron, it's better to combine it with folic acid and vitamin C at the same time for the absorption. And it's always better to take calcium and iron tablets apart, because they measure or they will disturb each other's absorption, especially the iron absorption. Do you understand? So either calcium in the morning, iron in the night, or iron in the morning, calcium in the night. So whatever is necessary. Got it? Next is the immunization. Did I talk to you all about it? The tetanus toxoid. Yeah. So next principle. And if necessary, vaccination. So immunization, commonly what we use is what? Tetanus, right? So the tetanus immunization, usually after 12 weeks, one shot, and then 0.5 ml, and then 6 weeks later, the second shot. So 2 doses, 6 weeks apart during the pregnancy. If necessary, you can give the third shot. That can give a coverage for about 2 years afterwards. But normally, commonly, we give 2 shots 6 weeks apart after 12 weeks. Okay, that is immunization. That is to prevent tetanus, which may be fatal for the women in pregnancy. Correct? Next, anti-worm treatment. Not absolutely essential, right? However, in countries such as ours, still the trend is there to give one deworming treatment, which can be done. So you can use any acceptable deworming method for the pregnancy once only, right? But it all depends on the country which you are living in, where deworming can be a principal law. It is not absolutely essential, right? So that covers the nutrient and that part. Next principle in the booking visit are the different kinds of histories that must be taken. Okay, what are these histories? Number 1, allergies. It is essential that you learn. If the patient dies of anaphylaxis because you have forgotten to take a history, that is your fault. There is no excuse for you to prescribe something and have not asked whether the patient has any allergies. It is the patient, of course, also must tell you, but if you have not asked and you prescribe that, remember before you put your pen to paper, right? Don't ever do prescriptions, texting. You put your pen to paper, and then you have not asked whether the patient has allergies, and you prescribe something and she dies of anaphylaxis, then it will be very difficult to defend yourselves. Okay, allergies. Second, history is family history. What are the most important things? Family history, diabetes. Whether she has a first degree relative of diabetes, right? Because then we have to screen her for diabetes here and any other problems in the family history. Third, any operations done on her. So any surgical interventions, any intervention on the uterus, for example, myomectomy. Usually if there's a myomectomy has been done, it has opened into the cavity, which is a full thickness scar. It's better to go for an elective cesarean section than to try for a trial of labor, because sometimes you can have dehiscence and rupture, right? If a bowel anastomosis has been done because she has had a road traffic accident, there may be a lot of additions inside. We'll also should try for a normal delivery than try and go for a cesarean section. If there has to be a cesarean section, then the most experienced person in the unit, right, should be doing it, because you can go right through bowel and cut the bowel and put the patient's life in danger if some surgeries have happened in the tummy. Is that clear? So surgical history is extremely important for you to decide. Medical problems which she has had, and we need to find out exactly what the medical problems are, whether it is under control, where she's been treated, what medication she's on, when did she last go to a clinic, to make sure that we get a complete medical history, because we will, from the clinic, from the minute, we have to refer them onwards to see for their follow-up for certain things. Heart disease, cardiology. Endocrinology problem there. Psychiatric problem to the psychiatrist. So we do the referrals from after looking at the past medical history and what she is on. Is that clear? Next, social history. It's a very, very, very important thing, social history. You need to know who she is, what she is doing, who her spouse is or partner is, what professions they have, and to find out whether they have problems. Domestic violence is one of the biggest underlying underground problems in a lot of countries, not in over here. So there are patients who are coming in with a lot of domestic violence going on. They may be assaulted at home. They may be under threat of, that they may be killed. There are lots and lots of problems, and especially in some countries will have warning signs where automatically in the history the warnings will go out. If the patient comes in for a lot of non-specific complaints all the time, there may be a problem where she's just coming, not because she's having problems, but she's getting assaulted at home. Next time she might not come, she might get killed at home. So therefore, a doctor needs to be trained to check and be suspicious of domestic violence. And therefore, when you are taking the social history children, ask open-ended questions. Do not ask close-ended questions. Like, how is everything at home? Is there anything that you want to tell me? Is everything okay with you? Right? Is there anything that you want to share with me? Do you all understand? These are open-ended questions which might provoke an answer where she might be able to tell you everything. And so you need to be on the lookout for these signs. And if there is domestic violence and you suspect domestic, and the woman comes out and tells you, okay, I'm getting assaulted all the time, then there are so many protection agencies, right? Government agencies that will come into play, which you need to inform them, and they will be able to intervene and maybe safeguard that woman's life. Do you all understand? So social history is extremely important, and you need to know whether they are having problems with drug addictions, whether their home is not good enough, whether they are able to travel quickly, whether they are so poor that you might need to get the social services involved. There are so many things in the hospital that we might not know that where we can get support for them, right? So those things we need to be aware as to what the patient is going through and to help them, and you need to know to help them. So a social history is extremely important for you to understand who your patient is, right? Got it? So that is social history. So then you need to know whether, so that I think that I have covered almost all the histories, right? So let me go through again. Rubella, immunization, whether they had their, immunization history. Folic acid, whether they have got it preconceptionally. Then past medical history, social history, family history, surgical history, right? 7. Right? So that covers the history parts, right? So that sort of ends the booking visit. Okay, if I forget anything, I'll get back to it. So once you have done all that, then your booking visit is over. And then you draw up a plan for her. For patients, we basically from there, we divide them into high risk and low risk categories, right? And the high risk and low risk can be different things. She might be low risk throughout the pregnancy and high risk during the delivery, like a past cesarean section. So it won't make a huge difference because she has had a past cesarean section during the pregnancy, but during the delivery, she becomes high risk. Do you all understand? But she may be high risk during the pregnancy and delivery. When? Pre-existing diabetes, mellitus, or hypertension. During the pregnancy, she can give problems. During the delivery also, she can give problems. Do you understand? So depending on the specific patient, after you have made the specific referrals as well, the next principle I forgot is multidisciplinary input. You get help from all the specialists to manage your patient. You don't do things alone. That is old days, right? Now we get the relevant specialists in for the relevant problems. So you pool the expertise and give the best possible lead to a patient. Got it? Next is what? The multidisciplinary input, and then of course you make the plan for the pregnancy, right? Next, you might meet them at, then once all the investigations come in 1 week's time, it's better to meet them, look at all the investigation and take all the necessary action necessary. Let it, sort out color that one. Then sometimes you might refer them to a fetal echo, right? Sorry, now that is a booking visit. The next visit is between 18 and 22 weeks. And what do we do? So we ask them to come back between 18 and 22 weeks. Sometimes we might ask them to come back at 16 weeks, because if they needed an oral glucose tolerances and they have vomited, then you might need to ask them to do it at 16 weeks. Also, if there are twins or multiple pregnancies, you might need to see them every 4 weeks or so to monitor the babies. Otherwise, usually a woman will come back to you again between 20 and 22 weeks, maybe 18 and 22 weeks. For what? We perform an anomaly scan there. How do we perform? Basically from head to toe and the uterine environment of the placenta, we look at the baby. So the brain, the skull, the sutures, the nose, the mouth, the palate, right? The chin, the pharynx, larynx, the bones, the heart, the lungs, right? The 4 chambers of the heart, whether the fingers are there, the bowel, the diaphragm, right? The bladder, the kidneys, the limbs, the genitalia, everything that we look at the baby, the cord, the placenta, localization, everything we do at between 20 and 22 weeks. So that is the anomaly scan. There are problems there. We might need to get another input by doing, ask a specialist to do the fetal medicine specialist, site specialized scans. Sometimes a neonatal, the fetal scan, echocardiography can be done if we have any suspicious, best at 24 weeks, so that the mother is ready if there's a cardiac problem, right? Then along the way, we meet them at 28 weeks, next visit. 28 weeks, what we do? There are children, 4 things that we need to be on the lookout for. Number 1, pregnancy-induced hypertension, where the hypertension, pregnancy-induced hypertension. So the thing which we do is we have to check for blood pressure, basically, right? Why do pregnancy-induced hypertension come at this point? It is thought that the placenta, there's a problem with placentation, right? The placenta does not develop properly in the early pregnancy. So what happens is, placenta to develop properly must have trophoblastic invasion. So the trophoblast must go into the maternal vessels, destroy the muscle coat and change the fetal vessels or the maternal vessels into tubes, so that blood comes through very fast into the placenta. So the mother has no control over constricting the vessels and preventing the baby from getting the blood. So basically it is controlling the maternal vessels by trophoblastic invasion. If that does not happen, the maternal vessels retain their ability to constrict and reduce the blood flow coming into the placenta. So if trophoblastic invasion doesn't happen very well, however, the fetus does not feel it much until about 24, 26 weeks, or maybe about 20 weeks, because whatever the placental tissue there seems to be all right for the baby. But then after about 20 weeks, the baby starts to grow rapidly. The placenta is not getting enough blood, and the placenta becomes ischemic because the usage is more than what it's getting. And then for some reason, the ischemic placenta produces something that causes it to go to the mother's body and damage all the organs in the mother's body, including the endothelium of the arterioles, which govern peripheral resistance, which governs blood pressure, right? So this damage causes the peripheral resistance to go up and therefore the blood pressure to go up, right? It damages the brain, it might damage the brain, and you get headache, nausea, and fits. It can damage the liver, and you get the liver function test will go up, right? It can damage the kidney. All the proteins will start to leak out of the urine. It will damage the bone marrow, and the platelets will go down, right? It damages all the systems in the body, and you have edema. It damages the epithelium or the lung. The blood will, the proteins will go out, the fluid will go out, and you have pulmonary edema. It damages all the vessels in the body. The proteins go out, with that the oncotic pressure is reduced. All the fluid will go out of the vessels, and there'll be hemo concentration of the body, and the hematocrit goes up, right? Do you all understand? So basically, at around 20, 24, 26, 27, they will develop pregnancy-induced hypertension. So you have to be on the lookout for that at 28 weeks. Second, you have to be lookout for diabetes. What is that? That is the oral glucose tolerance test. We have to do the oral glucose tolerance test. Oral glucose tolerance test we do when? Around 28. Why is it important at 28 weeks? Because the oral glucose, what happens is, because the placenta at this point produces human placental lactogen. The human placental lactogen is a fetal hormone. It goes into the mother and mobilizes the mother's glucose. It prevents the mother from using glucose. It converts her metabolism into free fetal FFA, or free fatty acids. So the mother has to or starts to use FFA for her metabolism and leaves the glucose for the fetus. It antagonizes insulin, it increases gluconeogenesis, it stops glycogen production. So basically it increases the mother's glucose levels. So across the placenta, baby is getting a lot of glucose. Now, if the mother's pancreas cannot keep up with this hyperglycemia, if there's a relative deficiency because of this increased production and demand, then she will develop diabetes. So this is the time she develops gestational diabetes. So you do oral glucose tolerance test at that point to see whether she has developed gestational diabetes. Clear? Third thing they develop is obstetric cholestasis. What is obstetric cholestasis? There are a lot of bile salts. They do not get excreted, right? Because the estrogen will block all the ducts, and estrogen and progesterone, and they will get bile salts will be deposited, but especially in the attalam, so they get itchiness. So you need to be on the lookout for that. The fourth thing is, this is the time, because of placental instability problems, the baby start to develop growth restriction. Now we call it small for gestational age now. So this is the time the baby will become small, right? So you need to do the placenta measurements and then maybe the scans to find out whether the baby is smaller than normal. Is that clear? That is the importance of the 28 week. So you do the screening there. Then we meet them at 32 weeks. 4 weeks later, routine scan, maybe we can start charting the growth from 28 weeks to 32 weeks. We start charting the growth there, right? So less than the 10th centile, the baby is small. More than the 90th centile, the baby is large, right? So that is macrosomia, and then small for gestation less than the 10th centile. So 32 weeks. Then we meet them at 34, where we do the blood pressure measure, everything. And then we meet them again at 36 weeks. 36 weeks, the principle at 36 weeks is what? We look for timing of delivery. We decide on the place of delivery. We decide on the mode of delivery, right? Those are the three important things we do at 36 weeks. Timing, mode, and place. Okay. So at 36 weeks, we decide, okay, if there's a problem, say for past 3 cesarean sections, the 4th section, yeah, we'll do it around between 37 and 38. If there's diabetes on insulin, yes, we will deliver around, if there are no problems, or about 38 weeks. If there's hypertension but well controlled, we'll deliver at 38. If there are no other problems, yes, we'll deliver at 40 weeks, right? Or we wait till 40 weeks and 3-4 days. So timing of delivery, we deliver that. Mode of delivery, we decide at that time. If there's a myomectomy has been done, yes, at around 38 weeks, we'll do a elective cesarean section. Okay. If there are no problems, we'll go for spontaneous onset. We'll wait till this one. If not, we'll induce. So we decide on the timing of delivery at that point. At the same time, we decide on the mode of whether it's going to be vaginal delivery or whether it's going to be a elective cesarean section. Do you all understand? So these are things we deliver at 36 weeks. Also, if the woman has thought about contraception, we have to talk about contraception at that point of time. Because contraception is never during the delivery. During the CSA, shall we cut the tubes? The woman might be in pain, distress and all that. She says, just cut the tubes, right? So you don't do it like that. At 36 weeks, you have to have proper discussion and decide. Otherwise, it is not valid consent. Got it? Right? So once that is done, after 36 weeks, then you meet them at 36, 37 weekly, 38, or until the admission, 38, 39, 40, right? During that time, if you want, you can do specialized in another scan or something, but we see them weekly to make sure that everything is all right. Okay? Then comes the admission. It might be at any point. And once they get admitted, if they're going for a normal delivery, and if it is an induction, right, or the spontaneous onset of labor, then there are certain principles in the induction. So you can induce them by doing artificial separation of membranes, right? And then you might use prostaglandins. You might use any form of induction. You can do you can put in a Foley catheter. All that you can do, and then they go into the labor room. And you have the first stage, second stage, and the third stage. So the first stage is usually until the cervix opens till about 3 to 4 centimeters, and then in that stage there are principles you have to see. So you have to give them analgesia, ask them to maybe walk about or even rest, right? And then you have to put them in the labor room usually after about 4 centimeters in length. Once in the second stage, there are lots of things that you have to decide about. What is this? There are principles governing the second stage. So you have to monitor the mother throughout the labor. You have to give them analgesia, which may be pethidine, phenergan, maybe morphine, or you can give them epidural. So that is analgesia, right? Then you have to monitor the fetus with auscultation or CTG. So that is one principle. Then you have to hydrate them well. So you have to give them fluids, right? You can ask them to drink. Then the other thing is you have to monitor the labor, which is very important. Monitoring the labor would mean contractions, dilatation, position, how the head descends, all that, skull mold, baby skull molding, abdominal descent, everything with a partogram, that is fetal monitoring. Then you have to talk about, so those are the principles during the labor which you need to talk about, right? So specific, say heart disease, we might need to definitely analgesia, we might need to give an epidural, okay? Then comes the third stage, that is when the delivery occurs. Now, on an epidural in a primip, you allow about 3 hours. On an epidural for a primip, multip, then multiparous woman, you allow about 2 hours for them to deliver, right? You don't wait until the end of that period. For if it is a after full dilatation, so if it is a if it is the what is this if it is 3 centimeters, initially I spoke about the first stage, which I think I call the second stage, because first stage is the latent phase and the active stage of labor up to full dilatation. Then the second stage is from full dilatation until delivery, right? In that, in a primiparous woman, on an epidural, we allow 3 hours. That is the maximum. But however, we start to do something by about 2.5 hours and make sure that the delivery is complete by about 3 hours. In a primiparous woman, on an epidural, we allow 3 hours. In a multiparous woman, With an epidural, we allow about 2 hours, right? Which means by about 1.5 hours, you need to do something, either instrumental delivery or a cesarean section or whatever, and get her delivered by the end of 2 hours, right? Why is that we give more? Is because an epidural may cause problems with contractions. The woman might not feel the pain to push down well, so therefore we give them a bit more time. No epidural in a primiparous woman, 2 hours, second stage, and in a multiparous, 1 hour. So basically 2 hours means without an epidural, by about 1.5 hours, you start to do something. By at the end of 2 hours, you should have completed the delivery. In a multiparous, you start to get them to push about 30 minutes or so. You start doing something and you finished off by about 1 hour post full dilatation. Is that clear? And then comes the third stage. Third stage is always active management of the third stage. What is active management of the third stage? You need to understand that very well. I know I have taught some of you all, right? So active management of the third stage is what? Once you are sure the baby is out, usually if either whole shoulders are or anterior shoulder, one of the shoulders out, then definitely the baby is coming out, or the whole body is out, doesn't matter. You give an oxytocin drug. What does the oxytocin drug do? It's a large dose given instantaneously, and that causes the uterus to immediately contract, because to stop the bleeding, we need the uterus to contract very well, so that the middle layer will crush all the blood vessels that was changed into pipes during the pregnancy, because the placenta receives about 500 ml of blood per minute, and therefore if the placenta surface continues to get that blood supply once the placenta is gone, it will continue to spurt out 500 ml of blood per minute. So you can imagine the amount of blood that's going to come out, and in 3, 4, 5, 6 minutes, they will be fatal. Therefore, the natural mechanism is for the uterus to contract violently after placenta separation. Because the middle layer is crisscrossed, and therefore all the blood vessels, large, those pipes go through it, contraction will immediately clamp the vessels and stop the bleeding. That is how a woman's life is saved after delivery, and it prevents postpartum hemorrhage. Active management is we are doing something about it. What do? We give a massive dose of oxytocin, 5 units, 5,000 international units, right? For us to continue labor, we give it in small doses, which is 32 milliunits maximum, 64 milliunits per minute maximum. We can start with 2 milliunits, 4 units, 6, 8, 12, 16, like that, only milliunits. 1 million is 1,000 of an international units. But to contract the whole uterus, we give 5,000 international units. Massive dose immediately, and that causes the uterus to contract. See, the placental surface is constant. The uterine surface contracts, and therefore the placenta is sheared off. However, because we are doing it artificially, we are doing a large dose artificially, if we don't do anything, the placenta will get stuck inside. So to get the placenta out, what do? We give control cord traction, right? But we have to give control cord traction when we are sure that the placenta has come out, sheared off. And what are these? There are signs of placental separation which we need to look for. That is lengthening of the cord, deviation of the uterus to one side, and a gush of blood. And then we give control cord traction to get the placenta out. Otherwise, we'll have a retained placenta. Is that clear? So that is delivery of the third stage. Right. So that is done. If the woman goes for a cesarean section, then it's preoperative, intraoperative, postoperative principles, right? Preoperative principles are we have to optimize the woman. We have to, any medical problems, we have to take certain things to prevent infection. For example, catheterization in the theater itself after cleaning, right? Then we have to prevent thromboembolism by giving her stockings, right? She has to be well hydrated to prevent thromboembolism. We have to get a proper consent, that is communication before the surgery. Then we have to communicate with the theater, and we have to send in a list right? All these forms under preoperative principles, okay? Then once all that is done, she goes into theater, and then there are operative principles which a surgeon needs to know, not at the student level, okay? Then post-operatively, there are certain principles where we have to look after the patient. Like we need to monitor the patient, we need to give analgesia to prevent infection, we need to give antibiotics, we need to communicate with the patient to tell what has happened, right? Then we have to prevent thromboembolism by getting out of bed and good hydration and mobilizing her very quickly. We have to take care of the wound or to prevent infections post-operatively, right? All these, we have to draw up a plan and tell her exactly what's going to happen in the plan. So all these are post-operative principles, which I am not going to talk about now, but you have to understand that there are principles governing the post-operative period as well. Once all this is done, then she goes to a puparium, okay? Now the puparium has certain principles which you need to look after. What are these? Breastfeeding. So she can have breastfeeding problems which you need to look after and advise. She can have engorgement, she can have mastitis, she can have abscess formation, she can have difficulties with breast feeding. So that is number one. She can have psychological problems. She can have the postpartum blues, she can have depression, and she can have psychosis. So any sign or small problem of having a problem, you need to get the psychiatrist in. I have had a patient long time ago jumping off the window, right? So therefore, sometimes you don't notice it, but so they just have this problem and they go. So if you notice the slightest problem, please get the psychiatrist involved. Make sure that they come in and talk to the patient, and they might take over the patient to make sure to prevent any large complications, right? So therefore, they might become suicidal. They might very rarely harm the baby, usually not. But therefore, suicidal is the biggest problem we might be having. So you need to be on the lookout for any psychological problems, right? Next is breastfeeding. Then postpartum infections, postpartum sepsis may be there. You need to be lookout them. So from head to toe, you need to make sure that you evaluate everything, including laryngitis, including breast problems, including upper respiratory tract infections, lower respiratory tract infections, right? Wound infections, kidney infections, episiotomy, endometritis, thrombophlebitis, all those can cause postpartum sepsis, which you need to be on the lookout for, especially for fever and all that, right? So those are the postpartum. Then of course you have to discuss with them about contraception in the postpartum period and arrange methods of contraception with them. And then after doing all that, they go back to the preconception clinic. Okay. So what we have done is we have gone through the complete cycle of a normal patient, and that is an obstetric cycle. Did you all understand now? Right? So if you meet the patient at 38 weeks, your history is what has happened until 38 weeks. And you need to ask, did this happen? And you say, okay, this. So that is your history. Okay. From there onwards until the preconception clinic is your management, which you are going to discuss. The philosophy which you need to understand, children, is that the different medical problems or different conditions have different obstetric cycles. Okay. Diabetes will have one cycle, heart disease will have one cycle, hypothyroidism will have one cycle, psychiatric disease have one cycle, where at certain places you will have to do certain special things to look at these women until the cycle is complete. So therefore, it will be very easy for you if you know these cycles, what to do in the preconception, what to do in the booking visit, what to do in the first trimester, what to do in the second trimester, third trimester, what to do during the admission, what to do during the delivery, what to do during the puparium. for these specific problems so that you will be able to talk about it for the history, and you can talk about the management for the history if you know the obstetric cycles for each of these conditions. So therefore, I will ask my senior registrar to post a list of conditions, and please formulate your own obstetric cycles, 50, 60 of these. Look at your books and do this, or you can do it in groups. As I've asked my group, there are 30, you can, so 2 each, right? So you can get together in groups, either share these obstetric cycles, do your own, but in a common format, so you all can share each other. And then obstetrics children, for your exam purposes and your life, is almost sorted. That is minus the practical skills, at least the theoretical part is partially complete for you all by doing. So it will make giving exams very easy for you all. Is that clear? Right? Okay. Now, so what is the time now? Well, I've been teaching for 2 hours now, right? Almost. But I think that's worth it because for you to understand the principles behind it. So as I told you, remember, all this was taught to me by my teacher, Dr. Dilip Vishwanathan, and that is what I'm giving to you all. And I feel that is one of the best ways which we can teach you all obstetrics, right? Do you all agree? All right. So that once you understand the principle, there are also a book which we have written, which is called Obstetric Cycles. That also might help you, but I would rather advise you all to write or do your own cycles, please, right? Where then you can learn and able to formulate your own cycles, and then you exchange it among yourself. So obstetrics basically done for your exams. You can write and answer any question you want to, right? Next component is I will teach you all to take a 5 minutes obstetric history, right? Which I'm going to demonstrate to you. Let me call my pregnant supposedly pregnant demonstrator, right? So I have made her pregnant, not me actually, theoretically, right? So she's going to come online. She's going to be 30, I can't remember the age which she chose, but she's going to be a patient, right? She's busy, she's chatting. Right. So I will just demonstrate. Kinkini, are you there online? Hello? Are you listening to me? Okay, Puta, I want you to come online in 5 minutes, right? Be there, then, right? Okay. Right, okay, good. Right, now, let me just, right. So let me just tell you how to take a quick history. So you listen to me, right? First of all, name, write it down. Name, age, occupation, and who she is. Introduction. Next, we go on to, right, an quick obstetric history, right? We ask her, okay, what happened to your first pregnancy? Whether it is a miscarriage, if it is a miscarriage, what was the period of gestation? Whether it was delivered by, whether it was cleared by ERPC or medically induced. If it is a delivery, okay, how old is the child? How was the baby delivered, whether cesarean section or vaginal delivery? If it was cesarean section, what was the indication? If it was the instrumental delivery, what was the indication? So instrumental delivery can be a lack of progress, right? Or a fetal distress. Cesarean section can be an abruption, whether it can be emergency or elective, it can be an abruption or any indication. Next is period of gestation which she was delivered. Next is the baby's birth weight and whether there are any complications. In your brain, if the birth weight does not match the period of gestation, then you have to be on the lookout. Say if the period of gestation is 32 and you have a 4,000 gram baby, there's something wrong, probably diabetes, or rhesus isoimmunization where the baby has swollen up, right? Okay. If the period of gestation is 38 and the baby is 1900 grams, there's something wrong. Most probably small for gestation. Do you understand? So they need to match up. If it is 32 weeks and the baby's weight is 2300, yes, it matches. So it's preterm. Do you all understand? So those are the things you have to check. So those are few points. Age, maybe whether it's girl or boy and name, that gives a personal touch. How the baby was delivered, what are the indications, birth weight, period of gestation, and whether they have any complications. Do you all understand? Once that is done, then you take each pregnancy like that. So it's 2-3 minutes quickly. Next, you take the LRMP, EDD, period of gestation. Sometimes the period of gestation, the ultrasound, EDD may be by ultrasound. So ultrasound scan EDD and the period of gestation. Got it? Once that is done, then you take all the histories very quickly. Allergies, rubella immunizations, folic acid taken or not, past medical history, social history, surgical history, family history, right? You take those very, very, very quickly and find out those histories, right? So history done. Do you understand? Then you do the general examination, right? And then you prescribe all the investigations, whatever it is, right? And then you finish off you. So you prescribe the medication, you prescribe the investigations, right? Discuss about all the rest which I told you about, basically about the immunizations and the general things that she needs to know about, right? Then that is done and you do the plan. You all understand? That is how you take a very, very quick history. Okay? Right? Okay. So I will now take the history quickly, and that probably after that we can conclude because we are down to 84. So lots of people are feeling sleepy, probably hoping to look at the recording later on. Poor Chamod, you could not log off because he's really at the top of my screen. So but he's smiling still. Good. Let me get the view because I need to find my supposedly pregnant. Where are you, Kinkini? There you are. Right, now I need to now do the pinning of us side by side. Okay, I don't know how he's going to. I am there. Can you speak up, child, because I can't find you now.
Yes, sir.
Yeah, okay, wait. I'm trying to get us side by side, which probably is. Have you suddenly disappeared?
I also can't remember how to do that. Used to do it.
Yeah. I used to do that because I used to, try and take Kinkini. Oh, there you are, child. You are there in the middle now, and I have disappeared. One moment. Add pin, maybe. Yes. Do you all see me side by side? Chamod, I can see ourselves side by side. Can you see us both on the screen?
No, it's only user, I guess.
Ayo, Kinkini. You have disappeared.
Then you have to spotlight both.
For everyone, okay.
You. Yes.
Who can you see?
Now we can see King Kini. Yeah, King Kini Kotaj.
Now?
Now you.
Right.
Either way, I think it doesn't really matter.
If I add a spotlight,
Okay, now done.
Okay, sir.
Now done.
you all can see us side by
Yes.
side.
Yes, yes.
Yes, sir.
Right. Excellent. Right. Okay. So I'm going to take a 2 minutes history basically from what I told you. Kinkini, are you all right?
Yes, sir.
Do you feel pregnant? No. Okay. Right. So she's our demonstrator. She has her MBBS. So she is the demonstrator in our department. So she has kindly agreed to help us for 2 minutes. Thank you very much, Kinkini. Right. And now she's our patient, and I'm going to take a very quick history. So you to understand that obstetric history taking children is not a very difficult task. You all understand? So I'm going to take a 2 minutes history, right? So I'll do it in English, right? Hello.
Hello, doctor.
Hello. Hello. I am Dr. Dhammika Silla. I'm one of the consultants attached to this unit. How are you this morning?
Hello, doctor. I'm doing good. And I'm Harshani.
Hello, Harshini. May I know what your age is?
I'm 33 years old. Sir.
Right. So what do you do, Harshini?
I'm currently engaged as an English teacher at a school.
Okay. So that's good. What classes do you teach?
Mainly the O-level classes, doctor.
Right. Excellent. And who is your partner?
Actually, he's currently engaged as an accountant.
Right.
So,
So good. Having a good life, right?
yes, sir, of course,
Excellent.
doctor.
Right. So is it all right if we take a small bit of information for you? Right.
Yeah, sure, doctor.
Right. Okay. So let me just again recap. So you are Mrs. Harshini. You are 33 years old, right? Right. Okay. So do you have children, or have you had pregnancies before?
This is my fourth pregnancy, doctor, and I have two children. But the first pregnancy was miscarriage, doctor. So,
Right. Okay. So what we'll do is quickly I will take some information about each of those. Okay. So
okay.
we'll start from the beginning, right? So the first pregnancy, what happened?
Doctor, it was a miscarriage. When it was like only 7 weeks, I started spotting. So when I went to the hospital, I was put some like medication, and I was just sent home after that. There were no other complications.
First one ended up in a miscarriage, and it was diagnosed around 7 weeks, and you had a medical induction, as I understand, right?
Yes.
So were there any complications afterwards?
No complications at all. Then I conceived with my second child a year after.
Okay, so let me ask some questions about that, right? So second pregnancy, but that is your first living child, right? How old is she?
Yes.
How old
Now
is
5 years. Now
it a boy
5
or
years
girl?
old, doctor. It's boy, doctor.
Okay, how old is the boy? Must be very naughty by now, right?
Now 5 years old, doctor.
5 years old, right? Okay. So how was that baby delivered?
No, it was a vaginal delivery. So there were no problems also.
Excellent.
So
What on the birth weight?
Birth weight was like 3 kilos and 120 grams, like
That was normal,
as
right?
I remember.
And
Yes, no.
when was it delivered by the date, or how many weeks do you remember?
Yes, 39 weeks. I went into a spontaneous labor.
So there were no problems. Any complications after delivery?
After delivery, it bled a lot. So like they
Okay.
even gave me 2 pints of blood.
Okay.
That's all, doctor. I was okay afterwards.
So you had a massive bleed, and you were given 2 units of blood. How
Yes,
did
yes.
you? Were you in the intensive care unit, or how?
Yes, doctor. I was there for like 2 days.
Okay.
But afterwards, I was put to the ward and discharged afterwards.
Excellent. Can you remember what your hemoglobin was when you were, discharged?
Not really, doctor.
Okay. So, but there were no problems in the follow-up. Were you put
No,
on
not
iron?
no,
Tablets?
it
Right.
was just the normal.
Right. So
fine.
is the baby doing well? The 5-year-old?
Yes, now. Yes,
Okay.
yes, now he's
Schooling
doing
in Montessori?
well. Now just started school this year.
Right. Excellent. So that is your first baby. What happened to
Yes.
your third pregnancy?
Third pregnancy, the baby was a bit large, so like had to go for emergency elective cesarean. The doctor said that we have to go for
What was the birth weight?
LSC. Birth weight was 4.2, and also I had diabetes also, doctor,
Right.
which
Okay.
was like diagnosed at
How
around
was the
third.
control?
The control was good. I was put on this injection also, insulin,
Okay. Can you remember
and
doses?
I was given 16 units as I remember, and the control was good. But since the baby was large, the doctor said I have to go for a cesarean section. So
So the control, if when did your diabetes start in this pregnancy?
at on third trimester, like 28 weeks, doctor.
28 weeks. So you were
Yes,
not diagnosed initially with diabetes, but later on you were diagnosed. So was it called
yes,
gestational diabetes?
yes, doctor. Yes,
Right. So what are the doses of insulin you were in at the last point? You must have.
16 units night,
Okay.
and I think 12 units in the morning. Can't remember exactly, doctor.
Right. So one dose in the morning, one dose in the middle, and then lunch, and another dose for dinner, right?
Yes, yes.
Right. Okay. So when was the baby taken out with the electrician? At how many weeks?
38 weeks,
At 38.
like, yes.
Right. So any complications?
No complications afterwards, doctor. And
You went well.
yes, yes,
Right. So that is the third pregnancy. And this,
yes,
I understand, is your fourth pregnancy, right?
yes, doctor.
Right. Okay. So now was that the second live child, the one, is it a girl or a boy?
It's a girl, doctor.
Girl. Ah, right. Okay. Right. So everything is well. Achieving
Yes,
milestones, everything is fine. Excellent. Right.
yes.
Okay. So let's get to your period this time. When was your last regular menstrual period?
I had my last period in April, on April 19th.
19th of April. Okay.
Yes,
Right. So we would probably say, let me just check because so 19th of April, right?
yes,
19th of April, which would mean, let's say, so your estimated due date according to this is the 24th of January 2022, right? Okay. So you have you are 12 weeks and 2 days today. Okay.
okay.
Right.
Okay.
Okay. So anyway, we are going to go ahead and do a scan to confirm those days today. Right. Let me just take you through a few more things which I want to look at. Have you had your rubella immunization during your school days?
No, doctor, I was not given rubella, but since this was an unplanned pregnancy, this time also I couldn't get my vaccination.
So I understand for the all three pregnancies, you have just, not got your rubella. Okay. Right. So that is number one. Have you been on folic acid before
No,
you
doctor.
conceived? You could
No,
not.
doctor, this was very unplanned pregnancy. So like I didn't expect.
Okay. Then any medical problems that you have at this point?
I'm on thyroxine, 100
Okay.
micromer thyroxine
So these are
every
recent.
morning.
I understand. Not the other pregnancy you did not have. Again, recently you were diagnosed with problems with thyroxine, right?
Yes, yes.
What is the dosage you are on?
I get 2 tablets, which is like 100 microgram altogether in the morning.
Okay. Who is looking after you?
I
When the
am going
thyroxine
for a
was
clinic. I'm going
right.
for a medical clinic.
Are you well controlled? When was your last test?
Yes.
Was it recent?
It was done recently, and the doctor said it's normal.
Right. You might need to visit the doctor again because you have to tell them that you're pregnant. So they might retest you and then, of course, may adjust your dosages for you again. Okay.
Oh.
Any other medical problems?
No, I don't have any other medical.
So any surgeries done on you other than the cesarean section which you mentioned? Any other operations?
I have undergone one appendicectomy and cholecystectomy when I was like very small.
Okay.
Not recently.
Any complications due to those surgeries?
No, I was okay after the surgeries.
Right. Any allergies?
I got this allergy for penicillin, doctor, only for that. But for that, I got anaphylaxis, and they
Oh.
even gave me lot of fluid and adrenaline. Uh,
Right. So it was
Likewise,
a very bad anaphylactic shock.
yes, yes, doc.
Right. Okay. So this is only for penicillin, right? Any other, no other medication you know
So
of?
far, nothing, not for any other drug or anything.
Right. Okay. Then any family history of diabetes, high blood pressure, any problems?
Well, my mother has diabetes.
Okay.
Other than that, my father doesn't have anything.
Right. So I think we found out who you are. You are an English teacher. Your spouse is an accountant. Are you?
Yes,
Is everything all right? Is there anything that you want to tell me about your family life? Any problems that you have, or
No,
concerns
doctor.
that you have? You're all
No,
right.
doctor. Yes, yes, I'm all right. And we have good family support. Even my mother is staying with me to take care of the kids. So we are doing all right, doctor.
Excellent. Excellent. Right, Harshini. So I think that concludes our discussion part. So what we'll do is we'll do a dating scan now, and then I'll take you through the rest of it. So, okay,
All right,
shall we
doctor.
give her a small clap, children? You all are muted, so I don't think she can hear you. So, thank you very much. She's our demonstrator, King Kini. Thank you very much for consenting
My
to
pleasure to
be
help you, sir.
online. Yeah, online in front of all these people. So that is a bit of a difficult, thing when you do that. But anyway, thank you very much. You did beautifully well. Thank you. Okay.
Thank
Right.
you.
Okay, so that is, so let me pin. Okay, now for everyone, right? Do you all understand how a history is taken, children? And that is a very, very quick history, although I spent a bit of time on that, but that gives us all the history that we want to know about the patient. Correct? So with that also, then there are certain things that you need to take. You need to ask them what happened in the booking visit, what about the investigations, what we spoke about, all those principles, whether those has been fulfilled, and then you take her through the journey as to find out whether everything has been okay, right? Okay. Okay. Right. So this, who is this?
There is a feedback from M20.
Hmm?
A gentleman or lady called M20. There is a feedback.
Yeah. So why is the gentleman or the lady coming onto my screen? Okay. Okay. Right.
But okay.
Okay. Let me mute you all. Right. That's fine. So that we have taken you through a general history. So what we'll do is, I think we will postpone our endometriosis questions for next time because it's quite late, and I think we have gone through a comprehensive obstetric history, right? And to recap, I have taken you through the obstetric cycle. I have taken you through the principles of the cycle. I have taken you through almost all the components. I have told you how to study. I have told you how to get slot in all the information so that you understand, right? And I have demonstrated to you how to take a comprehensive but a very short history, right, in obstetrics, which will be useful for you all when you all take histories from the patient. You all understand? So it is not difficult, right, when you take this, because that covers everything that you want to know. So one more thing which I want to tell you about, what G means, what para means, and what C means. Gravida, right, because you have to write it down. You don't ask the patient that. G is every biochemical pregnancy the patient has got, which is miscarriage, say a normal delivery, vaginal delivery, whatever it is, right? So in the particular patient that Mrs. Harshini, she is gravida 4, that is included in this pregnancy. Is that clear? Para means every pregnancy that she has undergone that has gone beyond 24 weeks. in the past. In the past, beyond 24 weeks is para. So in Mrs. Harshini, who we took the history, she is gravida 4, that is included. She is para 2 because 1 miscarriage, 2 babies, and this is the 4th. So in the past, she has had 2 pregnancies that has gone beyond 24 weeks. Okay, so she is para 2. C is children, any amount, right? So if it is twins, then maybe 2, 3, like that. Okay. Then, so remember, so the first pregnancy, if it is the first pregnancy, it is always gravida 1 para naught, or 0, right? If this is a second pregnancy, gravida 2. If she has 1 child from the last pregnancy, she is para 1. Got it? So that is how we write that. So it's always better to take the history first and write out your G's and P's later. Okay. So to sort of take you through quickly through the history, remember if it is a miscarriage, when it happened, what are the period of gestation it happened, whether how it was taken out, whether it was spontaneous, whether it was surgery, or whether it was medical induction, right? And whether there are any complications. If it's a pregnancy, how old is the child? What is the name? Which is a good thing to ask. Whether it's a girl or a boy. Then how it was delivered, when it was delivered, at what period of gestation, what was the birth weight, and whether there are any complications. If it is a rhesus negative patient, whether anti-D was given, right? So that is in one few sentences, you can take the complete obstetric history for that patient. Got it? Right? And then you go along that pathway which I taught you. That will make you quickly take a very good comprehensive obstetric history. Okay? So I think we have done quite a lot today. So we will switch on to maybe next session we will talk about, because I have to talk to you about gynecology, which is a different ball game, right? And there I will speak to you about the philosophy of who a doctor should be, and then with that I will discuss gynecology with you, and then maybe the session next I will answer the questions on endometriosis. Okay, agreed? Any suggestions, any thing that you need to ask me to conclude the whole sort of discussion? Any questions? So open 5 minutes. I will take questions and then we will wind up. Yes. Shamod is finally happy to be out of the spotlight. I'm bullying him because he's my student these days. Unfortunately, we cannot see any of the faces. Only now here online I can see these beautiful faces. Right. Any questions? No?
Regarding family history, you mentioned diabetes is only enough for the family history. Why don't we take any other family histories during
anything significant? So what you have to do is to, I just mentioned diabetes because it is the most important thing, right? However, anything that is significant, you can just ask, is there any problem or any disease in the family that you might think that you want to tell us or share with us, right? Then they will come out with the genetic problems if there are anything that, because family history, what we are interested to see whether there's anything in the family that may have any effect on this pregnancy. So, family history, you have to, if you are going to ask, there will be so many things, right? So therefore, it's best to ask whether there are any diseases or problems that you think that might be important that is there. So if there's anything significant in the family, and they will come up with it. Psychiatric problems, anything, so they can come up. Yeah. Yeah, so that point is well taken, yes. Okay.
and during the history taking, well, this may be a little bit of gynecology, but during the history taking, like in miscarriages especially, if there are recurrent miscarriages, like there are certain diseases which correlate with that. So those type of things, do we ask from the patient, or
Yeah,
do we
definitely.
just
Now, so special circumstances, this is a very general framework. So especially miscarriages are second trimester, right, or third trimester, then we will need to go in for a bit of a more comprehensive history. Especially we are asking about the period of gestation because we want to clarify it as to whether it is a first trimester or a second trimester miscarriage. If it's a first trimester miscarriage, but more than 3 in a row, then it becomes a recurrent miscarriage. If it is 1 or 2, then usually most of them are due to genetic abnormalities which are random. So therefore, we don't really need to ask much about it, right? However, if the miscarriage was after 12 weeks, say 14, 16, 17, up to about 24 weeks, then it becomes a second trimester miscarriage. In which case, we might need to have a bit of history, whether it was a painless, whether it was painful, whether they have specific problems, whether they were investigated, whether they have any preterm labors before preterm miscarriages. So all those we might need to ask if it is specifically if it was a second trimester, because if it was a second trimester miscarriage, there are a lot of evidence-based things that we can do to prevent a second trimester miscarriage during this pregnancy, right? Which may be treatment for urine tract infections, and if there is asymptomatic bacteriuria, we might need to give antibiotics that prevent second trimester miscarriage. Many use of progesterone throughout the pregnancy might prevent second trimester miscarriage. Then sometimes cervicals cerclage, or at least monitoring for cervical shortening can give us better outcomes. Then, of course, if there is, if we think that it might be due to certain diseases, aspirin, low molecular weight heparins, all those can reduce the risk of miscarriage. All right. So there are certain evidence-based things that we can do to prevent miscarriage during this pregnancy. So yes, if it is a second trimester miscarriage, you might need to take a more comprehensive history on that part. Yes.
One last question which I got regarding especially GPC, the
Yeah.
so like in that regarding twin pregnancies,
Yeah.
so if a patient or if a mother in this case has a twin, how do we put it as?
So gravida is always one pregnancy. Para is also one. The children you'll have to put as 2. Right. So,
Okay.
so if it was now this is a second pregnancy and early it was twins, it becomes gravida 2, para 1, C2. If you want, then you can put in Varahanatla twins, okay? So no problem there, right? So it doesn't have to be very strict, and you just put twins for yourself. That's all. That's fine. Because anyway, GPC, these are not very strict and rigid rules, because they are in your para 1. Anyway, you are going to say twins, right? And if you have information monochoroid, dichoroid, the birth weights, all these will differ now, whether there are complications, period, so that you can just put in the information. So it doesn't have to be very rigid, but these are the general principles. Any more questions? Okay, we'll wind up. So, okay, thank you for being there. 56 now, so we are gone down. So, I think most of them must be hoping to look at the offline thing, which I will upload, right? And probably from the up to the time they were up, they'll remember. From the time they were asleep, they can watch offline, right? Okay, so it's like the cycle. So hopefully they will complete the cycle from wherever they stopped watching until the preconception. Okay. Okay then. Good night, children.
Good night,
Thank
sir.
you.
Thank you
Thank you,
very
sir.
much.
Good night. Thank you, sir.
Good night.